nurse coordinator in the Community Health and Education Department at Ascension Providence Rochester Hospital. So thank you all for joining us for today's presentation on osteoarthritis with Dr. Fityan. And I'd like to, of course, say thank you to Marianne and the OPC, because really they have been the driving force for these programs, and that partnership is just so important to get the word out and so that all of you can know about these presentations. So we're really, really glad this has worked out during this very difficult time of this pandemic. It allows us to connect with one another and learn information, and I think all of it's super valuable. Again, I'd like to remind people to use that chat feature. So Marianne and I will be looking at that chat feature, gathering up the questions, and reading them off to Dr. Fityan at the end. So please don't be shy, please use that feature. And I'd like to now introduce today's presenter, Dr. Mohammed Fityan. He's an internal medicine physician with Ascension Medical Group, and he has a special interest in cardiology, and he's a Wayne State University faculty member. And his goal is really, as a doctor, to help patients optimize their health through preventative medicine. And outside of the office, he enjoys soccer, tennis, and travel. So please welcome Dr. Fityan.
Hello, everyone. Thank you so much, Stephanie and Marianne, for this great opportunity. I think this is the least we can do as physicians to pay back the least we can do for our community. And thank you for the nice introduction. Yes, as Stephanie mentioned, I'm Ascension Medical Group physician, also Wayne State University core faculty here, teach the internal medicine residents at Ascension Providence Rochester Hospital. So as you all know, today we're going to talk about osteoarthritis. The reason is when we talk about certain diseases, for example, diabetes, which I did last year, diabetes is maybe more for complications, for mortality. Osteoarthritis is one of the diseases that has, as you will see next in the epidemiology part, it's affecting many of our patients, and it's associated with high risk of disability. So we'll do our best to cover the topics that was mentioned earlier, understanding the disease, because I believe with any disease, this is the most important thing. You just don't want to walk into your physician's office and just hear what they want you to do. I think it starts with you as a patient to understand the disease, what's causing the disease, what else you can do, what changes you have to make you feel better. So I think that's the most important thing, is to understand the disease, and then of course understand the treatment plan. So quick overview of epidemiology for osteoarthritis. Arthritis in general is a term that refers to an inflammation of the joint. Maybe, as you will see in the next couple of slides, it's not exactly what osteoarthritis is, but this is just an introduction. Arthritis means inflammation of the joint. Osteoarthritis being the most common form of the arthritis, and it affects many joints. It depends on the risk factors, as I will go over in the next couple of slides. But the main joints that are affected are the hands, knees, feet, and hips. The pain is typically the most common symptom, but that's not the only symptom that brings the patients to seek medical attention, but it's the main one. There is substantial morbidity with osteoarthritis, including disability and reduced quality of life. Yes, osteoarthritis may be not directly related to mortality, but definitely it is a major condition that leads to disability, and it affects the daily activity and the quality of life. Osteoarthritis is the leading cause of lower extremity disability in older adults. Hip and knee osteoarthritis are accounted for 2.4% of all year lived with disability. So you might see this term with diseases that can cause disability. It's YLD, it's years lived with disability. So the trends in the year lived with disability from 1990 to 2016 showed that osteoarthritis is one of the top 20 that's the leading causes of year lived with disability, with 46% increase just behind diabetes. So that's why it's very important. One estimate of the lifetime risk of developing symptomatic knee osteoarthritis is 40% in men and 47% in women. Globally, 240 million people are affected, and out of the 240 million, 30 millions are in the United States, which has increased from 21 millions in 1990 and 27. Maybe the percentage-wise, like if you talk about 30 million, that's almost 10% of the US population now. So it's a little bit higher than the 1990, like 21 million, I think it's around 8 to 9%. So as you see, it's rising by numbers and by percentage. So what is osteoarthritis? We just said it's a type of arthritis, but what is exactly osteoarthritis? It's tricky because sometimes especially when I see a new patient, they come to me and I ask about their past medical history and they will just label it as I have history of arthritis. So as a physician, I have to make sure, because arthritis is a general term, I want to make sure what type of arthritis it is, because as you will see, the treatment, the manifestation, the course of the disease, management is completely different. So what is osteoarthritis? Osteoarthritis, we said, is the most common type and of arthritis. It often comes with age, and it often affects the hands, knees, and hips. Before I go into the pathophysiology or what happens exactly with osteoarthritis, I would like to talk about the normal joint anatomy. This is, for example, the knee joint. So what is normal? I always show the patient what is normal before I show them what is abnormal, because that's the only way for you to say, okay, yeah, this looks different than how it should be. So with any joint in the body in general, maybe with the exception of the spine, you will see two bone endings, just like here. They should not touch each other. The bone endings here are covered with what we call cartilage, and there is this is called the synovial membrane, which is like a sac that's holds synovial fluid. So yes, normally in a normal joint, there should be fluid, because some of the patients, when I talk to them and I tell them about fluids in the joint, they think it's abnormal. Yes, effusion, which is extra fluid, is abnormal, but you should have a fluid inside the joint. And this is all supported by a capsule from outside. So yes, this is the general joint anatomy. So you should see a nice space just to give room for the joint to move. And the cartilage should be intact to prevent any friction or any rub against the joint. This is the slide I wanted to show you. So on the left, you will see the normal joint. This is an example of the knee joint. This is the femur, this is the tibia, and this is the fibula. So on the normal side, you will see these two bones. There is a nice space there, and the bone endings are covered with cartilage. What happens with osteoarthritis, which is on this side, the main difference you will see, maybe this is advanced osteoarthritis, where what we call bone on bone. There is not narrow joint space. I think I need another view. Maybe that's why when we do an X-ray, we do two views to see if there is a space or not. But this is definitely a narrow joint space. And the other change you will see is in the cartilage, the covering cartilage is worn down compared to the normal. And a part of the disease process is bone spurs, or what we call it, the medical term is osteophytes. You will see that some in the joints of the hands, knees, you can see it or feel it on the exam. It's a bone outgrowth. So in the past, osteoarthritis was considered to be simply a degenerative wear and tear process, and therefore often misnamed as degenerative joint disease. However, the pathogenesis of the osteoarthritis is much more complex. You will see, even when we talk about the risk factors and what can lead to osteoarthritis. It's very complex, and there is no single pathway that leads to osteoarthritis. It's always a combination. Aging, genetic, trauma, lifestyle, obesity, many risk factors work together, and part of it is inflammation, as we will see next. So it's important to understand it for us as physicians, because when we understand the pathophysiology, that's how we understand what the treatment is, or how do we develop new medications for any disease, including the osteoarthritis. This is another example, but this is with an X-ray. The normal one would be on this side. So you will see this is one view. The two view will confirm that there is a nice space here. There is no space narrowing. I don't see any bone spurs with the osteophytes compared to this one. If you see, especially on this side, so this is the outer side of the knee. This is the inner side. The inner side usually takes more pressure from the body. That's why you will see the narrowing more on this side. And there is also thinning of the bone and the outgrowth. So that's one of the X-ray changes that we can see for the knee, for example. So risk factors, as I said earlier, there is no single pathway. It's not like rheumatoid arthritis. That's one of the important things to understand. Osteoarthritis is not like rheumatoid arthritis at all. With rheumatoid arthritis, it's an autoimmune disease when your immune system attacks the joint and the joint space and causes destruction, and the pathway is very clear. It's an autoimmune disease, and we know how to treat it, and we know the mechanism of the disease. So yes, the outcome maybe is worse because it's a progressive disease, but I think we understand more how can we treat it or how to target the treatment. Risk factors, there's many risk factors. One of the most common risk factors is age. Advancing age is one of the strongest risk factors for osteoarthritis. The condition rarely occurs in people younger than 40 years of age, but at least 80% of people over the age of 55 have some X-ray evidence of the disorder. I want you to pay attention to this because this is the earliest. If we do an X-ray for a patient who does not have any symptoms, we can still see changes of osteoarthritis even without symptoms like pain or swelling. However, not all people with arthritis on an X-ray have pain or other joint problems, as I mentioned earlier. The mechanisms behind this increased risk with increasing age, just like any other risk factors, is not well known. They did so many studies to find a direct correlation with single thing that is related with age, and there was no clear answer. Gender is another risk factor. Same thing, for unknown reasons, women are 2 to 3 times more likely than men to develop the osteoarthritis, and also even after they develop it, they are more likely to have pain. At least 30% of the risk of osteoarthritis is thought to be genetically related, with genetic factors being typically stronger for hand and hip osteoarthritis compared with knee osteoarthritis. I want you to pay attention the next couple of slides, and I will highlight it for sure. When we talk about osteoarthritis, the treatment, the risk factors, the correlation with occupation, it really depends, and even the course of the disease. It's different. It depends on which joint is involved. So as you can see here, 30% of osteoarthritis genetically related, but it's stronger with hand and hip compared to the knee or the spine. So those patients with family history of hand osteoarthritis are at a higher chance. But again, does that mean having a family history is the only contributing factor? Does that mean I will get it? The answer is no. Obesity, when I go over the risk factors, we have 2 groups. Some of them are modifiable risk factors, like obesity. Modifiable, that means that's something that you can control to a certain point, you can change. Unlike age, This is something non-modifiable. Gender, the same thing, and the genetics. These are things that you cannot control. Obesity is the one that is really which will make a difference in order to prevent and to slow the progression of the disease. So people who are obese are at high risk of developing osteoarthritis, and definitely losing weight may reduce this risk. And obesity represents one of the most important risk factors for both the incidence, for those who don't have osteoarthritis. If they are obese, they are at higher risk of getting it. And even the progression of the osteoarthritis depends on which joint are we talking about. So someone who is obese and now developed osteoarthritis, if you ask me, losing weight, would it help? Definitely, yes. This is actually part of the treatment. The response might be different though. If the patient has hand osteoarthritis and obesity, would lose weight help him as much as someone who has knee osteoarthritis? Maybe not, but still the studies show that it has effect on their symptoms and the progression of the disease. And as mentioned here, it's mainly at weight-bearing joints such as knee, hip, as well as for the hand. I will go into more details when we talk about the treatment. Body weight also influences the severity of the disease. With obese individuals, some big studies showed when they looked at symptoms, they saw that the patients with obesity experienced more severe joint pain and more joint degeneration when they followed those patients with with X-rays. Same thing, the effect of obesity on osteoarthritis is likely to be multifactorial, but the two main things, I mean, it will be mentioned three, but the two main things are increased load on the joint, mainly on the hip and the knee, and also decreases the muscle strength, which is part of the treatment. Many of you heard about muscle strengthening exercises. Why do we do this? In order to support the joint, because the joint is supported by muscles. For example, if it's the knee, there's muscles on above the knee, below the knee. Strengthening those muscles will help to support the joint, and that means it will be less load on the joint itself. So in those patients with obesity, they tend to have a decreased muscle strength on top of the increased load on the joint. So that's, again, it's multifactorial, but these are the two possibilities why patients with obesity have higher risk of osteoarthritis. Occupation is another important risk factor. Now, is this modifiable or not? Yes, it is modifiable to a certain point. I know it's not easy for someone who's doing this job just to quit and switch jobs, but unfortunately, yes, this falls under modifiable risk factors. As long as you have the chance to change it, is considered as modifiable. So how does it work? It's almost the same concept as obesity. Osteoarthritis of the knee, for example, has been linked to certain occupations that require frequent squatting and kneeling. And these are just some examples. Why? Same thing, more pressure, more load in the joint, and it's recurrent for a long time. This is for the knee. An example for the hip is farm work, construction work, and other activities that require heavy lifting and prolonged standing or walking several miles each day. Same mechanism, more pressure and recurrent pressure on the hip, which is a risk for future osteoarthritis. Spine, heavy physical workload is also an occupational risk factor that was found to be associated with the spine and neck osteoarthritis. They did a good study. They studied office workers with other groups to see the occupational effect on the patients with osteoarthritis. And usually when they study patients, a group of patients with anything, they try to randomize them. That means the two groups should be with almost equal weight, almost equal same medical conditions because they don't want any bias. They want to compare just based on the thing that they're studying. So in this example, compared with office workers, significantly greater risk of cervical spondylosis, which is a condition of the neck. Cervical is the spine, like the upper part of the spine, was found among meat carriers, dentists, and miners, possibly related to frequent extreme positions or high load being placed on the cervical spine. So that's the main thing, is the load on that joint. That's what they found with patients with these occupations. Injury. Injury is one of the things that if I see a patient who's younger than 55, let's say in their 30s and 40s, and based on my physical exam, I suspect osteoarthritis. It's really unusual for this group of patients. That's, as mentioned earlier, you would start seeing it on average as age of 55 or older, maybe more in females. But when I see a younger patient, I would dig more in my history to see if they had a prior injury, because definitely injury to a joint is a risk for future osteoarthritis of that joint. But this takes a long time. It's not like 1, 2, 3, 4, 5 years. It's more than 10 years after. So you will see substantial joint injury or trauma to a specific joint increases the risk of osteoarthritis in the future. The knee is one of the most frequently injured joints, just based on like sports. And the rupture of the ACL specifically, when we talk about joint injury, it's different. Any type of injury can happen, including fracture of the bones involved in the joint. But with the ACL, for example, the anterior cruciate ligament, one of the ligaments of the knee, is associated with early onset knee osteoarthritis in 13% of cases after 10 to 15 years. I see it with patients who had road traffic accidents many years ago. And then I see it more in the knee and the spine. Some patient would say like, yes, I suffered from spine injury 10, 15 years ago. And now they are here in my office with neck pain. And based on my physical exam, investigation, imaging, I see that they have osteoarthritis. So yes, unfortunately, this is another risk factor. Sports, mainly because of the load on the joint and the injury, so it covers both. The risk of osteoarthritis increased in people who participate competitively in certain sports that predispose to a joint injury. This includes wrestling, boxing, pitching in baseball, cycling, gymnastics, soccer, and football. We see this a lot for knee injuries and knee osteoarthritis in younger patients, the soccer and football. By contrast, does that mean, okay, I run a lot, I exercise, does that mean I have a risk factor, I'm at risk of developing osteoarthritis? No, the non-competitive running does not appear to increase the risk of osteoarthritis, but at the same time, the studies show this does not decrease it either. If the patient does not have osteoarthritis and they do this, that does not put them at a less risk to have osteoarthritis in the future. Okay, let me just check if there is any. Okay, perfect. Okay, now symptoms. We said earlier the patient still can have osteoarthritis without symptoms, but we don't do screening X-ray to find this. So why would the patient come and seek medical attention? The most common symptom and the most reportedly initial symptom is pain. But there are other symptoms associated with the osteoarthritis. So osteoarthritis most commonly affects, we said, fingers, feet, knees, and hip, and also, of course, the spine. It less commonly affects the elbow, wrist, shoulder, and ankle, except for patients with prior injuries. I just had a patient the other day with a shoulder replacement due to osteoarthritis. They had injury to it before, like many years ago, and now they come with advanced osteoarthritis. But the most common, fingers, feet, knees, hip, and spine. So pain is the main symptom of osteoarthritis. It's an important question, is is it worse or better with activity and the rest? For example, patient who comes with the hand swelling and pain. Two things come to my mind. Is it osteoarthritis? Is it rheumatoid arthritis? Because as a physician, I don't like someone who's coming to me, to my office with a general complaint. I order everything for them and see which one will come positive. No, we have as physicians to take accurate history, do appropriate physical exam. So the osteoarthritis, and without complications, there is no inflammation, major inflammation involved. So the patient should not have redness, swelling that is tender to touch. They should not have warmth of the joint, and the pain. They usually describe it as worse with activity, relieved by rest. Compared to patients with rheumatoid arthritis, you will see that the opposite. They cannot sit still. They say, whenever I get rest, I will start having the pain, so I have to walk around. So that's the difference between osteoarthritis and rheumatoid arthritis, for example. In severe cases, however, if the patient, let's say, depends on the course or the joint, of course, but in severe cases, the pain can happen even at rest, or can wake the patient up at night. But in early cases or early stages, it's definitely only worse with activity. The pain usually occurs over or near the affected joints, but sometimes and many times, especially with the knee and hip, it can be referred to other areas. For example, a person with the osteoarthritis of the hip may feel pain in the lower thigh or at the knee. Person with knee osteoarthritis may feel the pain in the upper shin. So that's why we do thorough physical exam and try to move the joint before because we don't want to miss anything. If it's referred to the knee, if it's hip pain referring to the knee, I don't want to just focus on the knee and miss the hip. So it's important, and as you will see in the next couple of slides, it's a clinical diagnosis. I will not need an X-ray. I will not need any blood work to diagnose it unless I'm suspecting something else. So a good physical exam and good history is very important in those patients. Stiffness is another early symptom that patients can report. Most likely morning stiffness. However, it can happen anytime during the day. And stiffness, that the patient would come to me and tell me, like, I have the pain in my hands, and whenever I try to open the jar in the morning to eat breakfast, I can't. I have to wait maybe 30 minutes before I can, because I can't make a fist because my hand is stiff. Same thing can happen with the hip. Same thing can happen with the knee. So it's a common symptom, and usually resolve well within 30 minutes. As a physician, this is important for me to know, because if the stiffness lasts longer, that might be I'm dealing with something different than osteoarthritis, like rheumatoid arthritis. It also recurs throughout the day. It depends on the level of inactivity. If the patient is inactive, so that's why it's in the morning, because when the patient goes to sleep, he's inactive, the joints are resting. When they wake up in the morning, they will have the stiffness, but it should go away within 30 minutes most of the time. Some people note a change in symptoms related to the weather, particularly more joint pain and stiffness in cold, damp, or low pressure weather. This is common in patients with osteoarthritis. So we talked about pain, we talked about stiffness, effusion, swelling. I just mentioned to you that having fluid inside the joint normally, that you shouldn't feel when I examine the patient, I shouldn't feel it, it's normal. But sometimes this, due to extra or excessive swelling, it can cause, it's called an effusion. And it results from accumulation of the excess fluid in the joint. That's another symptom, but again, you should see it in more advanced cases, not early. Crepitus is the medical term for crackling or grating sensation, which is the movement of joint is affected by osteoarthritis by this the patient will describe this sensation is because of the roughing of the normal smooth surfaces inside the joint. You remember that the two bones are covered by cartilage. So when this worn, as you can see, there's a worn down cartilage. The bones will be against each other. So whenever the patient moves their joints, they will feel this sensation, which we call it as crepitus. And again, it depends on which joint is involved. Another thing is in advanced cases of osteoarthritis is a change in the joint shape. Which can be a prominent symptom, especially in the small joints of the hands, on the fingers and the base of the thumb. If you can see here, the thumbs, this is called squaring of the thumb. The base of the thumb is affected. It's one of the joints, the most common affected joints of the hands in osteoarthritis. And if you can see, there are some nodes here, swelling of the middle and the distal joints here on both hands. So these are all in advanced stages of osteoarthritis. The osteophytes, which is the bone spurs we talked about, sometimes you can feel it, but in the spine or in the hip, you can't. And it causes swelling as well. Now, osteoarthritis diagnosis. As a physician, how do I give the patient the diagnosis of osteoarthritis? What information do I need? For example, diabetes. I need to check their A1C. I can check their blood sugar. I have some, other than subjective, I have some lab and imaging that I can do for other diseases. But for osteoarthritis, as I mentioned earlier, this is where our skills as physicians come with accurate history, detailed history, and physical exam. Most of the times, we don't need labs, we don't need imaging unless the presentation is not typical. I need to rule out other things. For example, everything is typical, but the patient is telling me that the stiffness lasts for 2 hours. That does not fit my criteria. I have to do maybe imaging or blood work to rule out other causes of the arthritis. There is no single sign, symptom, or test. Instead, yes, as I mentioned, is the history, which include the patient's age, comorbidities, which joint is involved, and of course, their symptoms. This is a quick example. For example, knee osteoarthritis can be usually diagnosed person age over 50. If the patient is younger than 50 with no history of trauma, then yes, I think I need to investigate more to make sure I'm not missing anything else. Pain, predominantly when weight bearing and moving the knee, because remember, pain at rest is not typical for osteoarthritis in early stages. Early morning stiffness lasting for just a short time. 30 minutes is the cutoff. Once the patient tells me it's more than 30 minutes, that means I need to investigate. A crackling or grating sensation, the crepitus that we talked about, especially when going up and down stairs. And hard bony enlargement, the bone spurs that these are typical for osteoarthritis. You will not see it with rheumatoid arthritis. We're not going to talk about rheumatoid arthritis today, but it presents completely in a completely different way. In general, osteoarthritis does not cause inflammation until unless with the osteoarthritis, the patient has history of gout and they have gout flare-up right now, or septic arthritis, which is infection of the joint on top of the osteoarthritis. So if someone comes to me with knee osteoarthritis, now it's swollen, tender to touch, warm, red, definitely I have to tap the joint to make sure I'm not missing gout or infection of that joint. The symptoms of osteoarthritis generally vary from day to day. This is common. The patient would say, yes, I was just taking Tylenol. I had a bad week last week, but for the 3 weeks before that, I was fine. This is very common. This is part of the disease progress. Similar symptoms to the above affect other joints, as we mentioned. As the hip joint is deep inside, we talked about this earlier, some of the typical changes with osteoarthritis you can't see, but it will be more prominent in the finger, for example, finger joints. Labs, which are not necessary, and imaging, it's only if we need to rule out other causes. Imaging, if we decide to do imaging, we always start with an X-ray to see. But for example, other than lab and imaging, if I see a swelling too, I have to tap the joint. So any swollen joint, when I say swollen, I mean, based on my physical exam, I suspected there is fluid. I have to tap the joint to make sure I'm not missing something more serious than osteoarthritis. Now, let's say we have the typical symptoms. We discussed, for example, we did not have to do x-rays or labs. Now, the patient has osteoarthritis. I think it's a good question that as a patient to ask your physician, what is the course? What's the prognosis of my disease? This is a disease. How is it going to progress? So the course of osteoarthritis varies first greatly between people and depending on which joint is affected for unknown reasons. Some of them are related to occupation and obesity and sports, for example. This group of patients, they will their courses, like the outcome is worse than patients without. For example, the pain and functional restriction due to osteoarthritis of the hip is most likely to worsen slowly. The reason is because the hip is one of the major points to support the body, and that it's always under constant load and pressure just from standing and walking. Whereas osteoarthritis affecting the finger joints often causes intermittent pain and stiffness while it is developing, but only minimal symptoms later on. So the outcome is better with the hands. I just want to see if there's any questions. Okay, so treatment. Why do I need to treat osteoarthritis? When I give the patient the diagnosis of anything, I tell them the reason why do we need to treat it. I just kept giving diabetes as an example. I will continue. I need to treat your diabetes to prevent complications. I don't want it to be too low or too high, because diabetes, if I don't treat it, you will have heart attacks, strokes, or kidney damage. Why do I need to treat osteoarthritis? What's my goal? It's very important to have this discussion with your physician. Again, I would say for every diagnosis, what are the goals? We will talk about the treatment options. What's the goal? We said one of the morbidity that are related to osteoarthritis is limited daily activities or disability or pain, or it could be all of the above. So I need to manage the pain. I need to help my patient to do their daily activities, maybe even go back to exercise and just go back to their lives with the best options possible. So these are my goals, and again, you will see it will depend on which joint and other comorbidities. So when we talk about the treatment, three different types. We have the non-pharmacologic or non-drug therapy. This should be considered with all patients with osteoarthritis, regardless of how severe, regardless of which joint is involved, because this showed the most benefit. The second group will be, I would say 4 groups. The second group will be pharmacologic, including oral and topical treatment. The third group will be, I will put them in a separate group and I will tell you why, the injections. And the last group will be surgery. So non-pharmacologic, no drugs, oral and topical treatment, injections, and surgery. The non-pharmacologic, the non-drug that I will talk about, this should be part of any, this should be plus any of the other treatment, even if you decide that, yes, I will treat this with steroid injections, for example, the non-pharmacologic should be also part of the treatment. So what does that include? This can improve arthritis symptoms and have minimal side effects. So for these two main reasons, it was studied and it showed benefit. And unlike all the other options, it showed like minimal side effects. And it's always the first treatment recommended by clinicians. And people who try these approaches often have varying degrees of improvement. Why? Again, I think it depends on what other risk factors they have. Two patients, both of them, they have knee osteoarthritis. I recommended this specific treatment for both of them. Patient A did great, patient B not so well. Yes, this can happen, and we see it all the time. Weight loss is number one. Other than this, again, you will see the strengthening exercise and the support. Weight loss is the best thing that the patient can do. We talked about this earlier. Obesity and being overweight strongly linked to the development of osteoarthritis, but also worsening of the disease over time. Weight loss, even a small amount, appear to lower the risk. When we talk about weight loss, even in obesity in general, it should be by percentage, because I can't tell you lose 5 kilograms and make it a general statement for all of my patients. It's always percentage, and 10% is should be the goal. If the patient is obese, I'm not talking about patients who their BMI is less than 20, for example. Overweight is a BMI over than 25. Obesity starts at a BMI of 30. So 10% usually gives you up to 50% improvement if it's combined with exercise. And of course, just example, for someone who's 200 pounds, they should lose 20 pounds. Over how long? Preferably over 3 months to up to a year. But once if you have, we have different pain scales. If we do it now and we do it after they lose the weight, we noticed that most of those patients are reported at least 50% or up to 50% improvement just by the weight loss and the exercise. It's not well established if weight loss, though, slows the worsening of arthritis, especially in the hands. So it's mainly in the weight-bearing joints, such as the hips and the knees, and which makes sense. We talked about it. Yes, the strengthening exercises. Remember, maybe your physician told you about this a lot for the same thing. Strengthening exercise, you're just supporting the surrounding of the joint. So less load, less pressure will be on the joint. Physical exercise, this is very specific. That's why I did not cover the details about this. Physical therapy for hand osteoarthritis is completely different than the wrist. It's completely different than the spine. So it's really, I cannot have a fixed regimen for everyone. So it really depends. You need a physical therapy evaluation to come with your own plan. But why do we need the physical therapy? Is to improve the flexibility, and again, you will see this a lot, strengthen the muscles surrounding the joint. People who exercise regularly, despite their arthritis, will typically have less pain and better function than those who are inactive. Once the osteoarthritis is diagnosed, yes, exercise showed that those patients will have their course and outcome would be better, and then they will have less pain and better function. Assistive devices, they don't have a direct effect on the course of the disease, but I would think about it just like the strengthening exercise. You are just adding, like, for example, canes, walkers, raised toilet seats. It's just to decrease the pressure on the joint itself, but it's not directly related to the treatment of the osteoarthritis in general. Drug therapy, that's very important because there's many updates about this. It's always topical. I prefer topical if there is no contraindication, if there is no many joints involved. For example, many joints of the hands, knees, hips, and because it becomes hard to cover all the joints with topical, but the topical NSAIDs applied to the skin over the joint can help with the relief of the pain. And to be honest with you, it's showing great results, on top of less side effects compared to the oral forms, the pills or the tablets. So the topical NSAIDs are going very well right now, especially if the number of joints are less. Topical capsaicin, I don't know if you heard about this. It's hot chili pepper. It's over the counter. It showed some good results, not as good as the topical NSAIDs, but you have to keep in mind some people experienced side effects, mainly burning and stinging, because the way it works, it works on the nerve endings. So it's just like a numbing agent. Some patients reported good results. Let's say the patient tried the topical, tried the exercise and everything, and now it did not help. That was our first line. Now the second line would be oral pills. We always start with the NSAIDs, the oral NSAIDs, unless there's a contraindication. But the problem is those patients, they cannot be on NSAIDs forever, and many patients, they already have a contraindication. When we talk about NSAIDs, what are we talking about? Ibuprofen, which is Motrin or Advil, naproxen, which is Aleve, or celecoxib, which is Celebrex. These are anti-inflammatory medications, and they can help a lot with the treatment, especially with multiple joints involved, and if the above treatment failed. The problem is it can cause stomach upset, can affect the kidneys, it can have cardiovascular risk factors. So we try to limit their use as much as possible, but it showed good benefit. Now, this is an update, not very recent update, but I mean, I hope it will help you today. Acetaminophen, which is the Tylenol, big studies showed there is no benefit or relief of osteoarthritis pain. So we are, as physicians, we are staying away from it, because I don't want to give my patients something that was proven that without benefit with side effects, because it can cause liver damage, especially in patients who drink alcohol or they take other medications that can affect their liver. So yes, Tylenol is not helpful that much, and did not include it in this presentation, but Tramadol for back pain, for osteoarthritis of the back, is not beneficial. Actually, it showed harm. So that's another one thing that I wanted to mention. So the patient took everything. Physical therapy did not help. How helpful is joint injection? Joint injection, you will, the only and the main thing, the injection that showed the benefit is the steroids, which is the glucocorticoid injection. However, we cannot give it more than 3 to 4 times a year because it can thin the bone and make the outcome even worse than the benefit. So you will see some physicians, they give it, it depends on how like the response to it. Sometimes every 3 months, sometimes every 6 months, but definitely we don't do it more frequently. They have side effects, just like any other medication, mainly the local effect on the joint, and it also it's a risk factor because there's a penetration. So there's always a risk of joint infection, which we see. I wanted to make sure, yes, this one. So the injections of the substance called hyaluronate or hyaluronic acid, it's commonly used, at least I would say 3-5 years ago. It's not recommended now. Not because of that it showed side effects, but it did not show benefit. Whenever we recommend against something, it's one of 2 things: either no benefit or side effects. So that's the risks are more than the benefits for those patients. So the only injection that showed benefit with still the risk for side effects is the steroid injection, maximum every 3 months. you will not be able to give it to all the patients in all joints. Of course, it depends on the joint. I wanted to make this highlight some of the ineffective, or the studies did not support any benefit. Shoe insoles, platelet-rich plasma injections. It was reported that some physicians they are using the electrical nerve stimulation. It did not show benefit. Acupuncture, no benefit reported, at least. Fish oil, the curcumin, which is the active ingredient of the turmeric. The Boswellia serrata, I have some patients mentioning it to me. These are all not beneficial. Some of them not beneficial, some of them they can cause more harm than even benefit. Surgery is usually reserved for severe osteoarthritis, and to assess the severity of osteoarthritis is a combination of symptoms, of course, and imaging. Sometimes the patient just comes to me towards the end of the course and they have severe advanced osteoarthritis. I do an X-ray, it's already bone on bone. There's really nothing to consider at this point, or they tried everything else, but unfortunately the patient did not improve, so those patients, they will need surgery. But it's important when we talk about any intervention, its risks and benefits. So those patients, they getting the surgery, they should be on the best physical condition possible. When I talk about surgery, of course, the final decision would be by the ortho surgeon, but I would tell them you have to accept that you will be committed to a rehab before and after surgery, and it might take a year for it. So they have to be prepared, like they have to know what to expect. Exercise and physical therapy before and after, as we mentioned. Few different types of surgery. I don't think I need to go over the details of the surgery, but I think the most common surgery is the joint replacement, which showed very good outcome. And now with the advanced techniques we have, it's easier with less side effects and complications. This is just an example. This is bone on bone, advanced severe osteoarthritis. The patient is not responding to other treatment, and this is after replacement, and you will see the nice joint space here. A lot of room for the joint to move. One other thing I will highlight, fusion. You heard about fusion surgery, especially we use this for the spine and the small joints, especially the fingers and the toes. But what is the fusion? From the name, you are just removing the pressure on the joint, and then you you fuse the two joints. So if a patient has to, that's why it's for the spine mainly. For example, if the patient gets it done for the finger, after they remove the extra joint material that's causing a pressure, there will be like two plates, and the patient will not be able to use that joint anymore. It will relieve the pain, will relieve the pressure. So the patient will have less pain, but not necessarily more function for joints other than the back, the spine. With the spine, no, like the outcome is really, really good. The last thing I will talk about for the sake of time too, I think this is my last slide. Can herbs, vitamins, or supplements help? We see this a lot with osteoarthritis or no osteoarthritis, with other diseases. When a patient comes to me with a supplement asking me questions, it's if I know that the answer, if it's something I reviewed before, I can tell them right away what I think about it, what the studies showed. If not, I will be more than happy to take the information, review it myself, and then give my recommendations back. But there's no strong evidence that supplements of any sort work on arthritis symptoms. That's true even for the glucosamine, that's the chondroitin too. Some patients use it, and I think it's like, again, there is no studied benefit. And if you want to try any supplement, check with your doctor first. Sometimes I'm not against it if it does not cause any harm and the patient is saying that it's working for them. I don't mind, but if it's showing any side effects, I would say no. And sometimes what is missing is there's interaction. Some supplements, if the patient on Coumadin, for example, or for depression medications, those medications they interact with a lot of supplements, so they have to be careful. I just want to finish my presentation with this from like all shall be well and all shall be well and all manner of things shall be well. Thank you so much for your time, and we'll be more than happy to answer questions.
Great. Thank you so much. This was really informative. And I have family that suffer from osteoarthritis, and wow, that was a great information and cleared up some of my questions. So let me ask a few from our viewers here. One of the questions that came was, is it harmful to continue exercise if it's painful to the joint?
If it's painful to the joint, no. Usually, again, what's the goal? Why do we ask the patient to exercise? To improve the joint flexibility and to strengthen the, so I always say there is no one exercise. I always ask for physical therapy to evaluate and give their recommendations. That's why, is it something that was recommended by a physical therapist or an exercise they just find that is
Did the person asking that question want to elaborate a little bit more by unmuting themselves?
That I'll unmute. This is my question. I started doing yoga and I have arthritis in both of my thumb joints. And part of yoga positions are on your hands and knees, and it's really painful. If it doesn't hurt them, I'm willing to work through some of the pain. But if it's harmful, then I don't want to do that.
I see. Yeah, that's. I think if it's not, I'm sorry, I misunderstood the question. I thought it's what's recommended as part of the physical therapy, but it's causing pain. But yes, for this, again, remember when we talked earlier about how does this osteoarthritis work? Obviously, by doing this, you are just putting more pressure on the joints, and yes, down the road it can be harmful, and it can cause worse outcome. However, it depends. Sometimes what I recommend is, if again, depends on the exact type of exercise, we can support the joint. Runners, non-competitive runners, if they have knee pain that is worse with running, I ask them to wear a brace. With the fingers, we have also splints for the wrist and braces too that we can ask them to wear to help lessen the pressure on the joint itself. But yes, in general, if it's causing more pain, that means it's more pressure. And I think you should stay away from them.
Okay.
Yeah, Sonia and I just wanted to tell you, Jane, that you might want to try chair yoga. There's some, the OPC has a virtual chair yoga class on Mondays and Wednesdays. You could join at 1 o'clock, or there's a lot of free chair yoga programs. If you go on YouTube, if you need any help, let me know. I found a really good one. But that's where you can kind of stay in your chair, and they do some really good exercises, but you're not putting that pressure like you do on the ground.
Thanks for the tip. I appreciate it.
Great. So Dr. Fityan, the next question is from a viewer that said that they're taking, and I want to make sure I say this correctly, Meloxicam on an as-needed basis, and they wanted to know if there's a prescription or non-prescription topical NSAID that they could use to reduce the amount that they're using the Meloxicam.
I would 100% support this. Even if they are on oral treatment or injections or whatever, I would support using topical. Now it's over the counter, like Voltaren gel. The topical NSAID. It has the active ingredient is diclofenac sodium, which is a type of NSAID. Capsaicin, again, it's another one that's over the counter. It's not a topical NSAID, but it's the red chili.
The capsaicin,
But
Voltaren was the name of the Voltaren.
Yeah.
Okay.
And just for everyone here, there is an app called withDr. It's a good app for prescription medications that you can put the name of the medication. It will give you instant coupons. That is most of the times it's even cheaper than your insurance. It's called GoodRx. I will put it.
GoodRx.
Great. Now, someone before you had your slide on the glucosamine and the asked if there's any help, but you had said something about glucosamine. There's no evidence to support it.
Yeah, there is no evidence to support any benefit, unfortunately. Yeah, the only topical injection that is helpful, but again with side effects, is the steroid injection.
Okay. Yeah, someone just went ahead and said that you're confirming that turmeric, glucosamine, fish oil, you don't recommend that, or you do?
It's not, my job as a physician is to say if it's helpful or harmful. It did not show any benefit when it was studied. Turmeric, for example, it has its own side effects. It can cause GI side effects.
Right.
Stomach upset, sometimes bloating, diarrhea. And it's very important. You can, as supplements, it's okay if it's not causing side effects, but I want to make sure you tell your physician, because some of those supplements, they interact with your other pills, especially blood thinners, depression medications, psych medications. Those medications, they interact with many other supplements. If you're taking it and you feel that it's helping, that's fine, but just make sure there is no interaction with other medications.
Right.
So it's always important when I ask my patients if they take any other medications, I always ask to make sure to include the over-the-counter medications so at least I can be aware and I can give my recommendations as well.
Okay. Thank you for that. I had a question myself. I'm a knuckle cracker.
Okay.
That was my same question.
I've gotten better, but I've definitely been warned that can cause osteoarthritis in my fingers.
No. If you do it a lot, then again, yes, that might cause more recurrent pressure on the joint. Then yes, but doing it every now and then, yes, it didn't show that it was not labeled as a risk factor for osteoarthritis. Okay. But if it makes you feel better, you do it every now and then, that's fine.
Yeah, right. And what about, when you were talking about the spine, yes. I was thinking about all these people using texting and smartphone. Do you feel like that when you mentioned the dentists sometimes have greater arthritis issues, maybe it's from looking down?
Yeah.
Is that kind of the same thing that we might be seeing in the future?
When they studied the dentist, when it's occupation, it's something that is consistent. That is something you do at least 5 days a week. For those patients, yeah. So any extreme positions of the spine, whether it was now it's being studied for younger patients actually as in the future. So there's two types of studies. Some studies, they look back, which we call retrospective, and then there's prospective. Prospective is they are following patients who are doing this and they see the effect in the future. If this is a risk factor, there is no final results yet, but I would say yes, definitely. It's the same concept. You're applying more pressure on certain vertebrae, or like on the spine. So yes, for the future, it's a risk factor. But again, because of the consistency of the dentist and those occupations, this is something they do for a living, so they do it every day. So they studied this group, and then definitely they were at a higher risk, yes.
Gotcha, okay. So someone wanted you to go ahead and repeat how to order the prescriptions again. They missed that part.
For
I don't know if it was about the GoodRx or...
No, what I'm saying is this app, you download it, it's on Android, it's on Apple.
Okay.
Whenever there is a prescription, sometimes the insurance will not cover, especially the topical, maybe topical NSAIDs, they will tell them it's over the counter. We don't pay for it. Use this app to put with the prescription. You need a prescription to use this app. When you put the medication information in there, they will give you the coupon, or they give you the best price around you. You will put your zip code and it will tell you. Most of the times you will find it as a free. So that's how you need the prescription, and you need to download the app and
Do you
put.
know the name of the app?
It's GoodRx. I
Oh,
just
it is
put,
the GoodRx. Okay.
I just downloaded it. Good RX prescriptions.
Gotcha. Thank you for that.
Yeah, this is very helpful for, again, sometimes you will find it cheaper than your copay for insurance, and sometimes you will
Wow.
find it the insurance, if it does not cover it, and then you have the prescription, you can use this app.
Very good. We all need that. That's important.
I use it for myself, so.
That's great. Good advice.
Very good. Well, I think the only other thought I had was, is there any link to foods that can put greater risk for osteoarthritis?
I'm sorry, did you say?
Eating, is your diet and what you eat, does that affect your joints?
Not the type of the diet, but at the end, if it causes any overweight or.
I gotcha.
Yeah,
Sure.
but like the diet itself, no.
Okay.
Sometimes we think that some diets that are antioxidants that have the anti-inflammation effect, just like the turmeric, for example, it has effect. It did not show any direct effect on the pain, the progression, or even the incidence of having the osteoarthritis.
And then one more question. How long, if you get an injection of a steroid, how long does it generally work for?
It depends. Unfortunately, with osteoarthritis, even the physical therapy response is different. But on average, it's 3 months. Some patients, they would say it helped me for 6 months, but usually 3 to 6 months. Definitely, we don't recommend it more than every 3 months because just like any other steroid, it's a strong anti-inflammatory, but at the same time, it can cause thinning of the bones, and it can cause more harm than benefit. Yeah, and again, depends on the joint, of course. Some joints, it's even hard to use the injection, and they don't recommend it. Okay.
Well, I think that's it for our time. And thank you so much, Dr. Fityan. This was really informative.
It was a great presentation. You're getting applause hands.
I really appreciate the opportunity, and thank you so much for joining me today, and have a great day, everyone.
Okay, thank you so much. This was great. Thank you, everyone, for being with us. Yeah, lots of claps for you. This was wonderful. I will have this presentation on YouTube. I'll send everybody the link. Please feel free to share it with others. Stephanie, are you going to send out an evaluation?
I'm hoping to do that, yes. So I'd like, look for that in your email, just a short evaluation, and just know that there's lots of programs coming up in November. So look for that, and, just contact me back. I'm happy to send information. Okay.
All right. Fantastic. Thanks, Stephanie. Thank you, Dr. Fityan. Thank
Bye,
you, everyone.
everybody.
Have a wonderful day and keep your bones healthy.
For sure.
Bye, everybody.
Bye.
Bye, Abraham. Bye, Judith. Good to see you.